So we'll start, I'll explain some basics of the anatomy and then we'll go to the diseases, because uh, to start with, I think for teaching you the anatomy of the middle ear, we'll need to show you diagrams and we'll have to prepare slides. Otherwise, you won't be able to understand. It's not that easy. That is probably the most difficult part of ENT in the undergrads level, as the anatomy of the middle ear. Okay, I'll discuss the basics. I'll highlight the important points that you need to understand, then we'll shift to the diseases. Okay, so let us start with the basic anatomy of the middle ear. So suppose say this is your pinna, right? So from pinna, here comes the external auditory canal. Okay, so we know the external auditory canal has how many parts? Two parts. The outer part is bony or cartilaginous? Outer part? Cartilaginous part. And the inner part is the bony part. So how much is bone? How much is cartilage? So always remember one thing. Our teachers used to say, "Kane cartilage com." Okay. So for ear canal, it is 1/3 cartilage, 2/3 bone. Okay. For nasal septum, it is 2/3 cartilage, 1/3 bone. Okay. Remember that? It's very, very simple mnemonic. So we have the ear canal and then we have the tympanic membrane. So right? So we'll discuss the anatomy of the tympanic membrane. I think, like I said, it will need another class. So there are ossicles, right? The malleus. A part of the malleus, the handle of the malleus, it attached to the layers of the tympanic membrane. So, like I say, this, suppose say this is the malleus. Okay. Then we have another bone attached to the malleus. What is it called? The incus. And the incus is attached to another bone. What is it called? The stapes. The stapes has two crurae, like two legs. One is the anterior crura and the posterior crura. Okay. So it gets attached to the oval window. Very good. So behind the oval window, what do we have? The inner ear. Okay. The vestibule and the inner ear. So, see, this is the external ear up to the tympanic membrane. Beyond the tympanic membrane, we have the middle ear cavity. And beyond the oval window, we have the inner ear. Right? So, this middle ear cavity is basically like a room. It's like a box. Okay. So, say, suppose you are in a tent or a box. One side we have the door. Okay. So, what is the door? The door is the tympanic membrane. But there is a curtain on it. The door is closed. Okay. But we have the tympanic membrane. The rest of all the sides are blocked. It's bony. So, one side we have the tympanic membrane. It's like a cube. All other sides are blocked. So, here lies your middle ear cavity. Okay. So, there is only one exit, like say a drain from the room, and that's the Eustachian tube. Okay. So, Eustachian tube is the drain of the middle ear cavity. Okay. So, Eustachian tube goes like this. And where does it open? Which part of the pharynx? Nasopharynx. And what is the swelling called there? What is the name of the swelling? It's called a torus tuberis. Okay. When you go through your books, you will be able to see. It's called a torus tuberis. So that's a elevation in the lateral wall of the nasopharynx where there is the opening of the Eustachian tube. Okay. It's just the cartilage pushes the mucosa a bit and we can see a swelling. So this is the Eustachian tube in there. So this is the nose, so this is the nasopharynx and Eustachian tube opens here. So most of the diseases of the middle ear cavity is related to one problem, the major bulk, that is the Eustachian tube issues. Suppose I keep you in this room, I block the drain. So every part of the human body has some lining. It can be a cuboidal epithelium, it can be a squamous epithelium, it can be anything. A stratified squamous epithelium or whatever. So every part of the body, every cavity has a lining, right? So what happens when there are cells in the lining? So there are secretions. Obviously, the cell will have normal metabolism going through it and will have some secretions coming on, okay? So what will happen if I block this tube? So there is no exit, right? So all the secretions that's coming from all the cells around here, like the walls of the middle ear cavity, is getting collected over here. This is the beginning of most of the diseases of the middle ear cavity. Okay, so I wanted to tell you this basic thing before starting the diseases of the middle ear. So now you understand how the thing looks like. Okay, so tell me, what are the most common diseases of the middle ear? So some diseases that we see every day, day in, day out, we see these diseases. So most common ENT problems are infections, right? So every now and then we see patients coming with different kinds of ENT infections. Okay, so most of these are acute infections, like which has happened in a few days. Not even weeks, say a few days, sometimes 1 or 2 weeks maximum. So the commonest problem is acute otitis media. What is that? Acute means it is sudden onset, or acute ideally means when it is a short duration of time. Otitis means inflammation, media means middle. Otitis means inflammation of the middle, inflammation of the ear, and media means middle. So acute otitis media is inflammation of the middle ear. Simple. So how does acute otitis media start? So what are the presenting symptoms? What is the etiology? And how do we deal with the problem? Okay. So the commonest cause, like I said, is the blockage of the Eustachian tube. How can the Eustachian tube get blocked? Mucosa, okay. See, tell me the common problems. Where does it open? In the nasopharynx? So you guys all have URTI, right? Upper respiratory tract infections, we all have. There can be bacterial viral infections in the throat. So there may be inflammation of the nasopharynx or the entire pharynx. So what will happen if there is inflammation? There is swelling of the tissue. So there is edema of the tissue. So if there is edema of the tissue, all the mucosa around the Eustachian tube opening may get swelled up and block the tube. So there is narrowing of the tube. Okay. So what will happen then? This goes into blockage of the tube. So this is the first stage of acute otitis media. It's called the stage of tubal occlusion. So when you're thinking of acute otitis media, be it a short note or giving an answer in viva, just think, how does it start? It starts with tubal occlusion. So once there is tubal occlusion, what will happen? There is collection of the fluids, right? So then we have a stage called stage of pre-suppuration. What is pre-suppuration? So it is the start of the infection. So initially, when it is just blocked, there is no infection. It's just some collected fluids in there. Okay. So now, if you have some fluid collected in your body and there is no drainage, it's just collected. So it will gradually develop secondary infections. That's very common. You have fluid in your gallbladder, it can develop in a pyocele. Anything, any fluid in a body space can get secondarily infected, right? So there is development of infection in this fluid. So that stage we call it as pre-suppuration, and there starts the major symptom of acute otitis media, that's pain. Patient usually complains of severe pain. Okay, it's usually sometimes throbbing in nature. Okay, and patient is unable to hear anything. Why? Because of decreased mobility of the tympanic membrane, because there is fluid inside. So if you are vibrating or putting some sound through a water filled body, will it pass through like normal air? No. So the conduction decreases and the patient cannot hear properly. Okay, so we have pain, decreased hearing, the symptoms developing in the stage of pre-suppuration. Okay, so there is increased activity of the lining again and infection starting. The next stage is stage of suppuration. So pre-suppuration followed by suppuration. So what do you mean by suppuration? Means pus formation. So now, firstly there was infection. Second, the body tries to restrict it. So it goes into the war with the whatever etiological agent it is. The most common etiological agent in acute otitis media is Streptococcus pneumoniae. Okay, and it's more common in kids. So once there is a bacterial infection, the body tries to restrict it. So there is inflammatory response from the body towards the pathological organism, etiological agent. So what does that cause? It causes formation of pus. Okay, there is necrosis, pus, and this collection of pus in the middle ear cavity forms the stage of suppuration. Suppuration, the stage of suppuration is also very painful. Why? Because it pushes the tympanic membrane out. Like I said, all other walls are bony. The pus cannot go anywhere. It's only one way out. It pushes the tympanic membrane out. So there is a bulge in the tympanic membrane. So we can see a very congested eardrum, because any inflammation will have hyperemia. There will be increased blood supply, congestion, and since there is pus inside, it's pushing the eardrum out. So we have a bulged tympanic membrane. Right? So this is the stage of suppuration, where the patient complains of severe pain continuing. And once, if now you say this is a tympanic membrane is 0.1 millimeter thick, right? So if there is increased pressure in the middle ear, what will happen? It may perforate and the pus may come out. That is one way of the infection going. The other way is you see a doctor, start treatment. So when a patient comes to us in the stage of pre-suppuration or suppuration, we start antibiotics, right? We start treatment, whatever it is. I'll come to the treatment later on. So if the treatment goes well and the body starts to respond, the patient will go into the stage of resolution. Okay, so that's the fourth stage. But if the patient does not take treatment in time and the infection continues to spread, maybe the organism is very virulent, not responding to antibiotics, not responding to medications, the patient will go into the stage of complications. Right? So from the stage of suppuration, everything is in the book. From the stage of suppuration, it can either go to resolution or it can go to complications. Right? That's very straightforward, nothing to be worried about. So, how do we treat acute otitis media? So, patient has come to you in your outpatient's clinic with severe pain in the ear. Most commonly a kid or a young aged individual, most commonly. How do you start your treatment? You see that the eardrum is congested, maybe bulged. Okay. So just tell me one thing. So you have gone to the wards, right? Medicine, surgery. I think you've all gone to the clinics. So how do you examine this patient? I'm not talking of general examination of all those stuff. Leave those behind. Anyways, they'll do all those basic things. I'm talking of local examination. So you see the ear, right? First you see the ear. So you do an otoscopy examination or a Booth's lamp examination, whatever is feasible. You see, like I said, a very congested bulged eardrum. So there may be discharge in the ear because there may be already a perforation and there may be collected discharge in the ear canal, or you can just see the bulge. So what is the next thing that you're gonna see? What is the cause? What is the cause? How did the infection start? Eustachian tube dysfunction, upper respiratory infection. So there will be other signs of URTI. The patients will have a very congested oropharynx. There may be very congested nasal mucosa. There may be nasal discharge. Typical symptoms of URTI will be there. A patient who doesn't have any symptom of URTI is very unlikely to be AOM. Okay? And there may be constitutional symptoms like fever, tachycardia, typical toxic look. All these things will be there because there is pain. Patient is having severe pain and obviously there is an ongoing infection. So how do you treat this patient? And one thing never forget, when you are examining the ear, we always examine both the ears. We never examine one ear. Whatever be it a simple wax, maybe an acute otitis media, chronic otitis media, maybe a malignancy, whatever it is. We always see both the ears. In your exam also, when you write, always write the mention about the other ear. It can be normal, that's fine, but you have to mention it. Okay? So, how do you treat this patient? Okay, so there is infection, we'll start with antibiotics, obviously. So, what I said, what is the most common organism? Streptococcus. So, what type of organism it is? Gram positive or negative? So, it's a gram positive coccus, right? So, what is the choice of antibiotic here? Penicillin. So, beta-lactam antibiotics work best for gram positive organisms. Okay, so usually we start with penicillin. So, nowadays we have moved on to oral penicillins like amoxicillin or injection ampicillin. Most of the times it's amoxicillin that works the best. What's the second choice? What can it be? Gram positive cocci. What are the other antibiotics that work against? You have gone through pharmacology, right? Or you are just studying it? You have finished pharmacology, right? So you should answer this. DNA guidance inhibitors. What is the group? Come on. Very sad. I don't expect this from you. Fluoroquinolones. Very good. So we have the fluoroquinolones as our second choice, right? Because they are all against gram positive organisms. So we have to remember one thing. Acute otitis, acute infections are mostly gram positive, right? In ENT. I'm not talking of UTI. ENT. And chronic infections are mostly gram negative. So when we are dealing with acute otitis media, it's a gram positive infection. Okay? And when we are dealing with chronic otitis media, it's a gram negative infection. Okay? Remember this? So simple tips for your exam, okay? So like I said, then another, what was the cause? What was the first thing that happened in this infection? Tubal occlusion. So what will you do about the tubal occlusion now? You have started antibiotics, okay? Tubal occlusion. জোরে জোরে শুনতে পাচ্ছি না. Anti-inflammatory, okay. Specific for tubal occlusion, I'm asking something specific for tubal occlusion. What do you commonly use? nasal decongestant drops, right? So we'll use something that will decongest the mucosa. So what does a decongestant do? It decreases the blood supply. So if there is decrease in blood supply, there will be decreased inflammation, obviously. So if there is decrease in inflammation, this Eustachian tube will gradually open up and the pus will be drained. So instead of going to the stage of complications, the patient will go towards the stage of resolution. Okay. Now, what are the complications? If the patient doesn't see a doctor, if the patient chooses to be the doctor, him or herself, what will happen? Rupture of tympanic membrane. Very good. So, the infection may increase, there may a lot of more pus developing in there, and the patient will have a rupture of the tympanic membrane. So, what is the next thing that can happen? So, one thing I didn't mention, I think I should before asking this question. So, see, like I said, this is the only drain. Okay. So, there is another space that middle ear leads to. Okay. That is called the mastoid cavity. Okay. So, if you see, the middle ear is like this mostly. We don't mention this because, so this is the Eustachian tube like I said, and there is another area through which the middle ear connects with the mastoid cavity. Mastoid cavity, you have gone through the temporal bone, right? You know what is a mastoid antrum is? Mastoid ear cells. So, mastoid ear cells act as a reservoir. So, if there is any infection in the middle ear, what is this thing called? Full name. It's called an Auditious antrum. So, Auditious is the name. Okay. So, this is the Auditious through which the infection can travel to the mastoid. So, what will it cause? It will cause a mastoiditis. So, the patient can have a acute mastoiditis. So, what will the patient classically complain of? Pain behind the ear. There may be severe tenderness over the mastoid area. Okay. What other things can happen? Where is the other space that this infection can go to? Inner ear. What can it cause? Labyrinthitis. Very good. Okay. So, what are the symptoms of labyrinthitis? Yes, very good. The patient may have dizziness. The patient may have vomiting. And all the symptoms I have said with vertigo. Okay, these things will develop. So, you have to be very cautious. If a patient has started with ear pain, has now come with dizziness, you can suspect a complication of acute otitis media. Okay? Because if it's an isolated labyrinthitis, it will not have ear pain. Right? Clear about this? So, another very important complication is sometimes, there is one nerve called the facial nerve which traverses through the middle ear. I think you have read this in your anatomy, may not remember it properly. We will go through the anatomy of the middle ear when we will explain those things in detail. So there are three parts of the facial nerve. So, two parts traverses through the middle ear cavity. So, and there is a thin layer of bone covering the facial canal. Covering the facial nerve is called the facial canal. Okay. So, there may be dehiscence of this bone in some people congenitally from birth. So, if there is an infection and pus an increase in pressure, it can cause pressure on the facial nerve leading to a facial paralysis. The AOM presenting with facial paralysis, we have seen many. It's not that uncommon. Okay. We have seen patients with AOM, but it usually resolves with treatment of the infection. So, it's usually transient. Once we start treating the infection, the pus goes down gradually. So, this is about acute otitis media. Okay, so now you understand the basics. Any questions? You can shoot any question you want. No, right? So another very common entity that we face every day is something, it starts exactly like an acute otitis media, but there is no infection. So what will happen? Suppose there is a tubal occlusion, right? And there is collection of fluids, but there is no infection. So what are the problems that the patient will face? কি হবে বল? क्या होगा? Hearing loss. So there will be fullness, but there will be no pain, and it is a chronic process. A patient coming with ear pain cannot be otitis media with effusion. So the second entity is called otitis media with effusion. Okay, OAB or serous otitis media. There are two names. Otitis media with effusion is the standard name. Some people call it serous otitis media as well. So there is acute otitis media is purulent otitis media, and serous otitis media is serous. So there is no infection. Okay, so it's very common in kids. Why? হ্যাঁ জল কত দিয়ে ঢুকছে Eustachian tube is one way traffic. ইনফেকশন ঢুকতে পারে উল্টো দিক দিয়ে, there may be retrograde infections, but জল নাক দিয়ে কানে চলে যায় আনকমন, কি একদম কিডসে যায়, কিন্তু it's not the cause. Like, see, there are two things you need to understand. One is developmentally, Eustachian tube is much more horizontal in the kids. So gradually as we grow up, it becomes more vertical. Okay, that's the reason pediatricians always tell the new mothers, so when you feed your child, always keep the head end up. Okay, why? If the head end is flat, the milk that the child is sucking may go to the nasopharynx to the ear and cause ear infections. Okay, so the pediatricians always say to the new mothers that you keep the head end high, but that is in the infancy. Okay, so serous otitis media is something that's more common in the school going children. Okay, so that age group, like 5 to 15 years of age. Okay, that's the more common age. So here we don't experience something like a horizontal Eustachian tube. No. Okay, you're forgetting one very, very important thing. So you have so we have the nose here, right, and the nasopharynx here. The Eustachian tube opening is there. So what else can there be that can cause an obstruction in there? Polyp. Polyp is in your nasal cavity, not the nasopharynx. There is no isolated polyps in the nasopharynx. Come on, very close. Tonsil then. You have come to tonsils, very good. So what is the nasopharyngeal tonsil called? Pharyngeal tonsil called? What? Adenoids. So nasopharyngeal tonsil, right? So you have gone through the Walder's ring. You know Walder's ring is, right? Okay. So there is another type of lymphoid tissue which is called the adenoids, which is there in the nasopharynx. It's in the roof of the nasopharynx. Okay. So kids will have big adenoids. Okay. And the thing is, when we grow up to the age of 10 to 11 years, the adenoids gradually decrease in size. Okay. Because kids depend mostly on milk. There's more chance of, milk is a colloid, so there's more chance of infections. So there's more lymphoid tissues in the oropharyngeal region. But as we grow up, we switch to different kind of food, and the adenoid tissues gradually, this lymphoid tissue gradually decreases. And over time, it becomes very small or vestigial. So in kids we'll have an enlarged adenoids. So suppose we see patients where the adenoid tissue has not regressed the way it should have. So there will be persistent enlarged adenoids that can cause blockage of the Eustachian tube. Nasopharynx se ache jinishta. So on either side, so from this year, these Eustachian tubes are coming into the nasopharynx, and we have the adenoid here in the nasopharynx, occluding the Eustachian tube opening. So adenoids is one of the most common cause of secretory or serous otitis media. So we have collection, the patient will complain of what? Decreased hearing. So most commonly what happens is the kid's mother comes, or the kid's parents come, they say the child is getting inattentive at school, or the teachers complain that the child is not responding like he used to do before. Okay, there is something wrong, go and see the doctor. So that's the thing. So there is collection of fluids. Whatever be the cause, there is tubal occlusion and there is collection of the fluids. So what we see, so this time there is no infection. So there is no congestion. The eardrum is still pearly white. Okay. So if the fluid is there for a long time, what will happen? So the body absorbs the water part, mostly, right? So the fluid will gradually become thick. So what will happen? It will form something like a glue. That's what we call a glue ear. So it becomes so thick and gluey that it cannot come out of the Eustachian tube. Even if you are giving decongestants or medications, it's not coming out. It's stuck in there. And you can see something like a very classical, when you'll do your clinics on my day, I'll show you some videos that I have taken of my patients. I cannot show you in the class. In the clinics I'll show you the classical serous otitis media. So if the patient does a Valsalva, you know what a Valsalva maneuver is? Physiology mein padha hoga. In a Valsalva maneuver, we block our nose and try to push the air through the Eustachian tube towards the ear. Okay. So whatever, if the air is being pushed through the Eustachian tube, you can see bubbles in the middle ear. Okay, so there are distinct air fluid levels. You can see bubbles and air fluid levels. I'll show you videos. I have some videos. Okay, so that's a classical serous otitis media. The chief complaint is, like I said, decreased hearing most of the time and typical oral fullness. The patient will complain of fullness in the ears. I'm unable to hear properly. Okay, so what is the treatment of these patients? Wall? You start with surgical treatments always. Start with something basic, na? Surgical treatment is definitely an option, but kids' parents won't go for surgery right away, right? That's the most common thing, and that's also not warranted. So what will you start with? So obviously you'll start with decongestant nasal drops to try and see if the fluid comes out from the nose, right? And then we give some mucolytic agents. Okay, so that the glue that has formed, it gradually dissolves, it becomes thinner, and so that it comes out easily. And we can give something called antihistamines. What is the role of antihistamines? In acute otitis media also in serous otitis media, this decreases the secretory activity of the epithelium. Okay, so when the secretory activity of the epithelium decreases, the amount of fluid collected also decreases. So the bulge or the pressure in the middle ear cavity gradually comes down. Okay, we tell the patient to do Valsalva. So most of the kids they cannot do, obviously. For adults we explain them how to do it and that helps. Okay, Done. Up to this it is fine. No need of any antibiotics. Serous otitis media, never write antibiotics. Okay. And the next, so even after doing all this, the patient is not responding. Still having this thick fluid collected in the middle area. So what will you do now? Surgical treatment bolchili bol. What can be the what surgery can you do? What is it called? Yes. It's called a myringotomy. Very good. So we put a small nick on the tympanic membrane and take the fluid out. Would you leave like that? Heal করে গেল, তারপরে heal করে গেল, then again fluid will be collected. So what will you do? You want the patient to come back to you in 2 months again and say, sir, again there is block. No. Right, you want a solution. So what would you do? We want a solution, right? We want a permanent solution to the problem. So like I said, we have to find out the cause of the Eustachian tube blockage. It can be an adenoids. Okay. It can be an antroconal polyp, any other polyp or tissue in the nose, like someone said, you said, right? Polyps. So nasal polyps going to the choana causing obstruction, or any other cause that's obstructing, we have to treat that if it is there. Sometimes we may not find any specific cause, maybe just an Eustachian tube dysfunction causing the problem. May not be any anatomical thing that is obstructing the Eustachian tube, but can be dysfunction of the Eustachian tube that is causing the problem. We will come to in Eustachian tube disorders, we will explain that. There are some diseases called patulous Eustachian tube, some other diseases of the Eustachian tube. We will discuss those in another class also. So the thing is, say it is something that's due to the Eustachian tube dysfunction, and you have already created a nick on the tympanic membrane. So where is the nick done? It is classically done in the, so like I said, so this which side of tympanic membrane is this? Anatomy পড়েছিস তো? ভালো করে ভাব। I need you to understand this. Never forget this. Ever. Always remember this. So when we are drawing a tympanic membrane, okay, right tympanic membrane will be tilted towards the right. Okay. So this is the right tympanic membrane. Okay. And the handle of the malleus towards the right. Okay. So this tympanic membrane is right tympanic membrane. So left one, it will be like this. Okay. Not this way, like. Okay. So if you see the anatomy of the middle ear, so the oval window is something that is more posteriorly placed on the medial wall of the middle ear cavity. So this is the lateral wall, right? Tympanic membrane is the lateral wall, and the medial wall we have the, so like I said, this is the lateral wall and this is the medial wall. So medial wall we have the oval window. So oval window is comparatively posteriorly placed. So say if we put a nick over here and there is a perforation, what will happen? The oval window is directly behind. The phase difference will be lost and there will be more hearing problems coming up. You understand? The air going in will directly go towards the oval window. So no vibratory movements. Okay, so we always prefer to put the incision in the anterior-inferior quadrant, more anteriorly. Okay, we avoid the posterior quadrant. So like he said, we were putting an incision and we know that the tympanic membrane will heal by itself. That's fine. Tympanic membrane has its own blood supply and we are creating a sharp surgical wound. So it will definitely be healed. Very unlikely that it will not heal unless there is some infection. So after doing a myodingotomy, we always tell the patient and the guardian that please make sure there is no water entry in the ears. Please make sure to keep your child safe from cold and cough. So any kind of infection will cause secondary infection in the middle ear cavity. So there will be poor healing. Right? So what we do is, so now if this membrane gets healed, what will happen? There will be again collection of fluid. Right? So we have until that problem, the primary problem, that's the Eustachian tube dysfunction or the adenoids or whatever it is not solved, this problem will recur. है ना? होते থাকবে তো বারবার। কিন্তু primary cause-টাই তো you have not corrected, right? So what will we do for the time being? We put a tube called a grommet through this perforation like this. There are two ends. It's like a tube. It looks like this. Both the sides are open. And through it, we put it like the tympanic membrane is like this. So we create a connection so that there can be a communication with the outer. তাতে কি advantage হবে? The glue or the fluid that is being collected in there will have a second way of exit. Okay? So what happens is, when the requirement is over, gradually the tympanic membrane heals in a way and pushes this tube out. So we do not need to remove a grommet. When the tympanic membrane gradually heals over time, it pushes the grommet out. But there can be instances, we have seen patients where the tympanic membrane has grown in such a way that the grommet has gone inside. But whatever, these grommets are usually made of materials which are safe. So even if they fall in the middle ear, usually nothing happens. There can be infections and sometimes we need to remove it surgically, but that's extremely rare. Normally it doesn't cause any problem. Okay? Because the tube is made in such a way that the inner part is smaller, thus this inner flange is smaller, the outer flange is much bigger. So instead of going in, it usually falls out. Okay? So that is the way of surgically handling the serous otitis media or otitis media with effusion. Okay? So what are the other acute diseases of the middle ear? So what happens is there is extensive destruction. So it's a very virulent organism, and like acute otitis media, it is acute necrotizing otitis media. So there is gross necrosis. So the entire eardrum is eaten up. There can be erosion of the ossicles. It's a very bad disease. We need to admit the patient, put on IV antibiotics, debride whatever in there. The patient, it doesn't usually have a very good outcome. There may be permanent hearing loss, permanent damages. We may need surgeries. So mostly it is treated conservatively. Once the infection subsides, we need to reconstruct sometimes. Okay? I have gone through the algorithm and the stages of acute otitis media. I think you have understood everything about this. Okay, mastoiditis I have mentioned, medications I have mentioned. So another entity is barotrauma. So when there is, okay, so I lived in a place called Cayman Islands. It's offshore Miami in the Caribbean islands. Okay, it was a tourist destination. I was there for around 2.5 to 3 years. So we used to see a lot of patients having this barotrauma. because of deep sea diving. It was a known tourist spot for sea diving. So a lot of patients will come complaining of severe pain in the ear, sudden onset. And sometimes it takes a lot of time for the Eustachian tube to start functioning again. Okay, so these are the very common basic diseases of the middle ear. So after acute disease, what would we have? We'll have the chronic disease of the middle ear. Okay, and the commonest chronic disease is a chronic suppurative otitis media. Okay, I think we have only 5 minutes left, so it's unwise to start a new topic. But I will just outline one very important thing. So when we are dealing with what is the difference between acute and chronic otitis media? So there are multiple definitions across different books. The standard is we take 3 months. Okay, for otitis media. If you say 3 months, it can never be wrong. Some people say 6 weeks, some people say 4 months, so it varies a little bit. But if you say 3 months, that's a standard during your exam. But the pathophysiology is different. Okay, so acute otitis media is an acute infection that you treat, you cure the patient goes home, done. A chronic otitis media is something, it's an infection this patient is suffering from a very long time. Maybe months or even years. Sometimes we have patients who have come with symptoms lasting for like 15-20 years. Okay, so it's a chronic infection of the middle ear cavity. So what can be the cause? Like I said, it can be a perforated eardrum, or it can be other aggressive diseases like cholesteatoma and everything. So there are basically two types of chronic otitis media. One we call is a mucosal type or the tubotympanic type. So what is it? So if you go through the anatomy of the tympanic membrane, so there are two parts, the upper part and the lower part. You can see or you cannot see. Difficult for you. So this is the upper part and this is the lower part. Right. So upper part is called the pars flaccida and the lower part is called the pars tensa. So you need to read the anatomy of the tympanic membrane very well, because that's a long question. Okay, that's a full 10 marks question. Anatomy of the tympanic membrane and some applied questions along with it. So at least 6-7 marks on the anatomy. Okay, so you have to read it very well. What is the angle? What is the dimension of the tympanic membrane? What are the layers of the tympanic membrane? What are the parts of the tympanic membrane? What is the arrangement of the fibers? Everything is very, very important. Okay, so when you start reading middle ear, start with the anatomy of the tympanic membrane, then go through the anatomy of the middle ear. Okay, we'll have the classes on that. I think we just had external ear, so we'll have classes on tympanic membrane and the anatomy of the middle ear. So if there is an infection or chronic infection involving the pars tensa, okay, it's usually a safe variety or a mucosal type or a tubotympanic variety of the chronic otitis media. But if there is any disease that's involving this pars flaccida, the upper part, so it's a bad kind of infection. It needs urgent treatment. It's called a squamosal variety or a aticoantral variety of chronic otitis media.